Hey everyone, and welcome. Today we are tackling a really big one, something you'll definitely see on your board exams and for sure in the clinic: pulmonary hypertension. Now, I know it can seem super complex, but I promise, by the end of this, you're going to have a rock-solid framework that just clicks. Let's jump in.
So here's our game plan. We're going to start with the basic definition. What are we even talking about? Then we'll get into the 5 different causes, because the why changes absolutely everything. After that, we'll cover how the patient presents, how we lock in the diagnosis, and finally, how we treat it. It's a step-by-step approach to make it all stick.
All right, first things first. What, at its core, is pulmonary hypertension? Well, it all boils down to one simple concept: way too much pressure inside the lungs' arteries.
Okay, this is your high-yield number. If you remember nothing else, remember this one. The official definition is a mean pulmonary artery pressure of 20 millimeters of mercury or higher while at rest. And super important, this isn't just a guess from an ultrasound. This number has to be confirmed with the gold standard test, which is a right heart catheterization.
But, pressure is only part of the story. For a lot of these cases, what we call precapillary pH, there also has to be increased resistance in those blood vessels. We measure this as pulmonary vascular resistance, or PVR, and the magic number here is 3 Wood units or more. Just picture the blood vessels themselves squeezing down, making it that much harder for the right side of the heart to do its job. So we have a number, but that doesn't tell us why the pressure is high. And with pulmonary hypertension, the why is, well, it's everything. The cause is what dictates the entire workup and treatment plan. And this brings us to the super important WHO classification system. And to make this really easy to nail down for the PANCE, I've got a great mnemonic for you. Pa loves lung clot mix-ups. Seriously, commit that little phrase to memory and you'll be able to pull up the 5 major groups in a snap. Let's break down what each of those letters stands for.
Okay, let's run through it. PAH is for Group 1, pulmonary arterial hypertension. This is where the small arteries in the lungs are the primary problem. LOVES is for Group 2, left heart disease. This is the most common cause you're going to see. Basically, the left heart is failing and all that pressure just backs up into the lungs. Our next word, lung, is for Group 3, lung disease itself. Think COPD or sleep apnea causing low oxygen, which makes those vessels clamp down. Clot is for Group 4, chronic clots or CTEPH. This one is so critical to catch because it can actually be cured. And finally, mix-ups is for the mixed bag of causes in Group 5, things like blood disorders or sarcoidosis.
So now that we know all the potential causes, what does the patient sitting in front of you actually look and feel like? Let's dive into the clinical presentation.
The biggest problem here is that the early symptoms are just so vague. Getting short of breath when you exercise, feeling tired, a little lightheaded. That could be a million things, right? But as the disease gets worse and that right ventricle really starts to fail, the signs become unmistakable. Passing out when they exert themselves, a swollen belly from fluid, and big-time leg edema. And when a patient is short of breath just sitting still, well, that's a very bad sign. On your physical exam, you're really hunting for clues that the right ventricle is struggling. You might actually see the jugular vein bulging in the neck. That's your elevated JVP from pressure backing up. You might even feel the chest wall move as that overworked ventricle contracts. We call that an RV heave. When you listen to the heart, you can hear this loud, almost slamming P2 sound because that pulmonic valve is shutting against crazy high pressure. And as the right ventricle stretches out, the tricuspid valve doesn't close right and you'll hear a murmur. These are your classic telltale signs.
Okay, so you're suspicious. The patient's story and your exam are pointing you in this direction. What do you do next? Well, the diagnostic workup follows a really clear and logical path.
Here's your 4-step plan, straight up. Step 1, you suspect it. Step 2, you screen for it. And the best initial test is an echocardiogram. It can give you a pretty good estimate of the lung pressures. Step 3, you play detective and investigate the why. Which of those 5 groups does this patient belong to? You'll use tests like a chest x-ray, ECG, and a VQ scan to rule out those chronic clots. But step 4, and this is the absolute key, you have to confirm it and get exact pressure measurements with a right heart cath. No shortcuts. Your ECG can give you some major clues that the right side of the heart is just getting crushed under all this pressure. You'll look for signs of right ventricular hypertrophy, basically the muscle getting thicker. You might also see signs that the right atrium is enlarged, which can show up as these really tall, pointy P waves. It makes sense, right? The atrium has to squeeze way harder to get blood into that stiff, high-pressure ventricle.
And on the chest x-ray, the classic sign you're looking for is big, beefy central pulmonary arteries. They just look really prominent because they're dealing with all that pressure day in and day out. At the same time, the vessels further out in the lungs might actually look smaller than normal.
And let's just hammer this point home because it is so important. An echo can get you thinking in the right direction, but you absolutely never, ever start these powerful, expensive, and potentially risky medications without confirming everything with a right heart cath. It is the one and only gold standard, period.
All right, let's bring it home with our last section, management. The single most important thing to understand here is that the treatment is completely different depending on the cause. You cannot, I repeat, cannot treat all pulmonary hypertension the same way.
So for group 1, that special group where the arteries themselves are the problem, we have these very specific vasodilator drugs that target 3 main pathways. We can block the endothelin pathway, we can boost the nitric oxide pathway with drugs like sildenafil, or we can supplement the prostacyclin pathway. A lot of times patients end up needing a combination of drugs that hit more than one of these targets.
Now for everyone else, groups 2 through 5, the strategy is totally different. We do not use those specialized group 1 drugs. In fact, they can be harmful. Instead, for group 2, you treat the left-sided heart failure. For group 3, you treat the lung disease and give oxygen. For group 4, it's all about blood thinners for life and sometimes surgery to clear out the old clots. And for group 5, you guessed it, you treat whatever the underlying root cause is.
So if you take away one single thing from our time together today, let it be this: etiology is king. The cause is everything. Figuring out why a patient has pulmonary hypertension is the absolute key that unlocks the correct diagnosis, the right workup, and the only effective treatment plan. And I'll just leave you with this question to chew on as you head out into the clinic. Knowing how sneaky those early symptoms are and how devastating the late-stage disease can be, what can we do? How can we get better at catching this disease earlier, before that right heart is damaged beyond repair? It's the big challenge for all of us.